Hello friends, today we are going to learn about anatomical landmarks in maxilla and mandible. For maxilla we'll learn in this video, and for mandible we will learn the landmarks in another video. So, why study of landmarks is important? The anatomy of edentulous ridge in the maxilla and mandible is very important for the design of a complete denture. The consistency of the mucosa and the architecture of the underlying bone is different in various parts of the edentulous ridge. Hence, some parts of the ridge are more capable of withstanding force than the other areas. Hence, thorough knowledge of these landmarks is essential before making any impression. So, let's start with anatomical landmarks in maxilla first. The anatomical landmarks in maxilla can be divided into limiting structure, supporting structure, and relief areas. First, we'll be studying about limiting structures. So, what are limiting structures? Limiting structures are those structures which determine and confine the extent of the denture. Following are the limiting structures which are present in maxilla. These are labial frenum, labial vestibule, buccal frenum, buccal vestibule, hamular notch, posterior palatal seal area. Labial frenum. So, what is a labial frenum? Labial frenum is a fibrous band covered by a mucous membrane that extends from the labial aspect of the residual ridge, as we can see in this diagram. This is a labial frenum. Labial frenum has no muscle fiber, hence it is a passive frenum. A V-shaped notch should be recorded during impression making. This V-shaped notch is required to be left during impression making and while making the cast, because if we will not leave this V-shaped notch, then the denture can be easily displaced during masticatory motion. Labial vestibule. It is that portion of the oral cavity which bounded on one side by teeth, gingiva and alveolar ridge in edentulous mouth of the residual ridge, and on the other side by the lips. So, in this one side teeth, gingiva and alveolar ridge is present, and on another side lips are present, and the cavity which is formed in between these structures is known as labial vestibule. Labial vestibule runs from buccal frenum on one side to the other and the labial side of the ridge. It is divided into two compartments by labial frenum, namely the right and left. The vestibule is covered by lining mucosa, and the orbicularis oris is the main muscle of the lip. Its tone depends on support received from the labial flange of the denture and the position of the artificial teeth. Its fibers run horizontally and it has an indirect displacing effect on the denture. The muscles in this region are thin and their influence is minimal. The labial and buccal border of the denture are not important for a border seal because the lips and cheeks create a facial seal. Hence, the border of the denture are not very much important. Buccal frenum. The buccal frenum separates the labial and buccal vestibule. See, if this is a vestibule, and this is a frenum. This separates this part and this part of the vestibule, hence it is called frenum. This is buccal frenum, which is separating this labial and this buccal part of the vestibule. It has attachments of following muscles. First is levator anguli oris. It attaches beneath the frenum. Second is orbicularis oris, which pulls the frenum in forward direction, and buccinator pulls the frenum in backward direction. We have to take care to remember this. Orbicularis oris pulls the frenum in forward direction and buccinator pulls the frenum in backward direction. These muscles influence the position of the buccal frenum, hence it needs greater, wider and relatively shallower clearance on the buccal flange of the denture. Buccal vestibule. Buccal vestibule extends from the buccal frenum anteriorly to the hamular notch posteriorly. The size of the buccal vestibule varies with the contraction of the buccinator, position of the mandible and amount of bone loss in the maxilla. The ramus and coronoid process of the mandible and masseter modify the size of this vestibule during mouth opening. When the mouth is open and the mandible is moved from side to side, the coronoid process of the mandible will come near the distobuccal portion of the maxillary sulcus. The distal end of the buccal flange of the denture should be adjusted in such a way that there is no interference to the coronoid process during the mouth opening. Hamular notch. What is hamular notch? Hamular notch is a depression situated between the maxillary tuberosity and hamulus of the medial pterygoid plate. See, if this is a maxillary denture, this is a ridge ending, this is the hamular notch area. Hamular notch, or we can see with another diagram also. The denture is ending here, muscles. This is the hamular notch area. Hamular notch is a soft area of loose areolar tissue. The tissues in this region can be safely displaced to achieve the posterior palatal seal, and the distolateral border of the denture base rests in the hamular notch. The denture border should extend till the hamular notch. If the border is located anteriorly near the maxillary tuberosity, the denture will not have any retentive properties because the border seal is absent when placed over non-resilient tissues. Posterior palatal seal area. Posterior palatal seal area. This is the soft tissues at or along the junction of the hard and soft palates, on which pressure within the physiological limits of the tissues can be applied by a denture to aid in the retention of the denture. We can see in this diagram this is a ridge, this will be the posterior palatal seal area. posterior palatal seal area. Posterior palatal seal is the area of soft palate that contacts the posterior surfaces of the denture, and it is the area between the anterior and posterior vibrating lines. It prevents air entry between the denture base and soft palate. Let's learn some of the function of the posterior palatal seal. Posterior palatal seal aids in retention by maintaining the constant contact with soft palate during the functional movements like speech, mastication and deglutition. It reduces the tendency for gag reflex as it prevents the formation of gap between the denture base and the soft palate during functional movements. It also prevents food accumulation between the posterior border of the denture and the soft palate, and it also compensates for the polymerization shrinkage. Posterior palatal seal area can be divided into two regions based upon anatomical landmarks, namely pterygomaxillary seal and postpalatal seal. First of all, let's learn about pterygomaxillary seal. Pterygomaxillary seal is the part of the posterior palatal seal that extends across the hamular notch, and it extends 3 to 4 mm anterolaterally to end in the mucogingival junction on the posterior part of the maxillary ridge. Let's see it in diagram. As this is a maxillary denture, this is a ridge ending. This is pterygomaxillary seal. The hamular notch is located between the maxillary tuberosity and hamular process of the sphenoid bone. It contains loose connective tissue and few fibers of tensor veli palatini muscle covered by a thin layer of mucous membrane. The position of this membrane changes with mouth opening, hence it should be recorded accurately during impression making. The posterior extent of the denture in this region should end in the hamular notch and not extend over the hamular process, as this can lead to severe pain during the denture wear. Postpalatal seal. This is the part of the posterior palatal seal that extends between the two maxillary tuberosities. As we can see in the diagram, if this is a denture, this is a ridge, this part of the posterior palatal seal area is known as postpalatal seal, as it is running between the two maxillary tuberosities. These are the tuberosities and it is running, extending between these two tuberosities. When we are recording posterior palatal seal, we have to remember certain points, such as the posterior border of the denture should not be placed over the Mid-Palatine Raphe or the posterior nasal spine. If there is a palatine torus which extends posteriorly so that it interferes with the posterior palatal seal, then the tori should be removed. If any tori which is hindering the denture or is present in between any denture or in future will be affecting the stability of the denture, then we have to remove that tori. The position of the Fovea Palatina also influences the position of the posterior border of the denture. The denture can extend 1 to 2 mm across the Fovea Palatina. If a mid-palatine fissure is present, then the posterior palatal seal should extend into it to obtain a good peripheral seal. In patients with thick ropey saliva, the Fovea Palatina should be left uncovered, or else thick saliva flowing between the tissue and the denture can increase the hydrostatic pressure and hence displace the denture. Vibrating line. Vibrating lines are the imaginary line across the posterior part of the palate, marking the division between movable and immovable tissues of the soft palate, which can be identified when the movable tissues are moving. We can also say it is the imaginary line drawn across the palate that marks the beginning of motion in soft palate when the individual says ah. It extends from one hamular notch to other. It passes about 2 mm in front of the Fovea Palatina. The vibrating line should lie on the soft palate, and the distal end of the denture must cover the tuberosities and extend into the hamular notches. It should end 1 to 2 mm posterior to the vibrating line. Another school of thought considers the presence of 2 vibrating lines, which are anterior vibrating line and posterior vibrating line. Anterior vibrating line. Anterior vibrating line is an imaginary line lying at the junction between the immovable tissues of the hard palate and slightly movable tissues of soft palate, as we can see in this diagram. Ridge is ending here. This is our denture. So the vibrating line will be this. This is vibrating line. Vibrating line. Vibrating line can be located by asking the patient to perform Valsalva maneuver. In Valsalva maneuver, the patient is asked to close his nostrils firmly and gently blow through his nose. It can also be measured by asking the patient to say ah in short vigorous burst. And the anterior vibrating line is Cupid bow shaped, as I have already shown you in diagram. Posterior vibrating line. Posterior vibrating line is an imaginary line located at the junction of the soft palate that shows limited movement and soft palate that shows marked movement. As we have read anterior vibrating line, it was a junction of immovable hard palate and the slightly movable soft palate. Here it is entirely present inside the soft palate only, but it is present in junction of the slightly movable and movable part of the soft palate. Let's understand that in diagram. See, these were the ridges. This is a denture. Here, as we already saw, this is our anterior vibrating line. So our posterior vibrating line will be like this. This is posterior vibrating line. Vibrating line. Supporting structures. Supporting structures are the load bearing areas. They show minimal ridge resorption even under the constant load. The denture should be designed such that most of the load is concentrated on these areas only. The posterior lateral slope of the hard palate is primarily stress bearing area and the Rugae area is the secondary stress bearing area. So, supporting structures include hard palate, residual ridge, Rugae and maxillary tuberosity. First of all, we'll read about hard palate. Hard palate. Hard palate is the anterior region of the palate which is formed by the palatine shelves of the maxillary bone which meet at the center to form the median suture. We can see in the diagram. This is a denture. This is alveolar ridge. This is our suture for hard palate. This entire area is hard palate. In hard palate, this green area is secondary support area and this blue area is primary support area. The horizontal plate of the palatine bone forms the posterior part of the palate, and the submucosa in the mid-palatine structure is extremely thin. Hence, relief should be provided in the part of the denture covering the suture. This central suture area, we have to give relief. The horizontal portion of the hard palate lateral to the midline acts as the primary support area, and the trabecular pattern in the bone is perpendicular to the direction of the force, making it capable of withstanding any amount of force, as I have already shown you in the diagram. This blue part was the primary support area. Hard palate, Rugae area acts as a secondary support area. The incisive papilla, nasopalatine canal and mid-palatine must be relieved. Residual ridge. The portion of the alveolar ridge and its soft tissues covering which remains following the removal of the teeth is known as residual ridge. As the name suggests, residual, whatever is left. The ridge which is left after removal of teeth. This is residual ridge. Residual alveolar ridge resorbs rapidly following any extraction and continues throughout life in a reduced rate. The submucosa over the ridge has adequate resiliency to support the denture. The crest of the ridge may act as a secondary stress bearing area. This crest area. This may act as secondary stress bearing area. Loosely attached tissues along the slopes of the ridge cannot withstand the forces of the mastication. And the posterior lateral portion of the residual ridge is primary stress bearing area. Rugae. Rugae are the mucosal folds located in the anterior region of the palatal mucosa. As we can see in the diagram, this is a palate. These folds which are present here in anterior portion of the anterior region of the palate, these folds are called rugae. Rugae act as a secondary support area. The folds of the mucosa play an important role in speech, and metal denture bases reproduce this contour, making it very comfortable for the patient. Maxillary tuberosity. Maxillary tuberosity. It is the bulbous extension of the residual ridge in the second and third molar region area. As we can see in the diagram, this second and third molar region area, this is called, in both sides, this is called maxillary tuberosity. tuberosity. If we see from another angle, if this is a maxillary ridge, this area will be maxillary tuberosity. Maxillary tuberosity, posterior part of the ridge and the tuberosity are considered as one of the most important areas of support because they are least likely to resorb. Now let's study about releif areas. Releif areas. These areas resorbed under constant load or contain fragile structures within. So we have to give relief in these areas as the name suggests, because they are getting resorbed under constant load, so we cannot put any load over there. The denture should be designed such that the masticatory load is not concentrated on these areas. Relief areas include Incisive Papilla, Mid-Palatine Raphe, Fovea Palatina and Cuspid Eminence. Incisive Papilla. Incisive papilla, it is a midline structure situated behind the central incisor. As we can see in the diagram, these are central incisors. This is incisive papilla area. Incisive papilla. Incisive papilla is the exit point of nasopalatine nerves and vessels. It should be relieved. If not, the denture will compress the vessels or nerves and lead to necrosis of the disturbing areas, and paresthesia of the anterior palate may occur. Mid-Palatine Raphe. Mid-Palatine Raphe is the median suture area covered by thin submucosa. Let's see in the diagram. This is the denture and this is a suture area. This is median suture area. This is called Mid-Palatine Raphe. This also have to be relieved during denture making. And this area is the most sensitive part of the palate to pressure. Fovea Palatina. Fovea Palatina is formed by coalesce of the ducts of several mucous glands. This acts as an arbitrary guide to locate the posterior border of the denture. We can see this in the diagram. If this is a denture, this is Mid-Palatine Raphe. These are Fovea Palatina. The position of Fovea Palatine also influences the position of posterior border of the denture. The denture can extend 1 to 2 mm beyond the Fovea Palatina. The secretion of fovea spreads as a thin film on the denture, thereby aiding in the retention. In patients with thick ropey saliva, the Fovea Palatina should be left uncovered, or else the thick saliva flowing between the tissue and the denture can increase the hydrostatic pressure and displace the denture. Cuspid Eminence. Cuspid Eminence is the bony elevation on the residual alveolar ridge formed after extraction of canine tooth. It is located between canine and first premolar region. As we can see in the diagram, this is residual alveolar ridge. This area where canine is removed, eminence is present in residual alveolar ridge. This is called cuspid eminence. Thank you for watching my video. Friends, if you like my video, please subscribe my channel and ring the bell icon for latest updates.